Yeah, good afternoon, friends, respected chairpersons, my dear friends, and then thanks for the opportunity, organizers, for the heart failure meeting. What I'm supposed to speak is on protected TAVI, that is usage of protected devices during TAVI procedure as the time arrived, because there are variable schools of thought. Some felt it should be used, some not. Let us see what the data shows. This slide brings best wishes from Apollo Group of Hospitals, where we are trying to network and collect the data. And about 200 plus cases, what we have done in our place, I think about 10 plus were used the Sentinel device. That is my confession statement before. But we can always learn and adapt to newer things. Then stroke, before going directly, there are some basic procedural characteristics and procedural techniques where you can prevent the occurrence of stroke. Like cath lab is not a place where to show your power. If you have some resistance, avoid pushing it too much, and then some of the case examples I will show. But basically, the sheath advancement techniques, usage of avoiding of predilatations, and if there any carotid disease there, all should be treated. Now, what we are planning, talking, is patients who do not have those, and then probably plan procedure for TAVI. And one thing which is suitable is usage of embolic protection devices. Let us see. So, stroke risk we all know, though it is decreased significantly, but it's not trivial. So, we have to see why this thing started. This started with a partner one trial raising concern of increased neurological risk of TAVR. When they compared with surgery, obviously in those days, these are all high risk patients, and compared to surgery, which is there here, the TAVR incidence of strokes were higher, be it be immediate post and then probably minor or TIAs or 30-day strokes were more with TAVR. That's where the thought process went in, and they tried to see how could decrease the TAVR. But with more and more data, full partner trial database shown now, I think it is shown that there's actually, in fact, surgical AVR only has more stroke incidences compared to transfemoral TAVR. So that doesn't mean that surgery is a gold standard. We always wanted to have less and less strokes. That's how I think new research is going on. Why the TAVR stroke is important in TAVR is because once the patient develops stroke, the discharge gets delayed, and then patients need to stay in rehab or more longer in the hospitals, and only few percentage of the patients who get TAVR go home early. This is a very welcome thing to note that starting from the first generation valves to now the latest valves, the incidence of stroke is decreased right from 5%, which was there in partner one trial, to about 1.7% with the most latest generation valves. Then even in the Sentinel ID trial, the control arm also had 2.9%. The present valve stroke rates, in spite of not using, also are less than that. This is a welcome thing for all of us to note. So the incidents have significantly decreased. How it is happening, what are we doing is, by this thing, this is one of the case examples which we had, is you hold some material which comes out in this Sentinel filter, and that's how we think that it is definitely it should decrease the stroke incidence. This initial intention to treat trial with symbolic protection devices showed that there was some decrease, but the decreases were not significant in both this intention to treat analysis. Then the randomized trial people wanted to show, that's where I think Samir Kapadi and others started this protected TAVR study. Objective was to usage of this cerebral embolic protection, would it decrease incidence of strokes. So this is a large trial, again 1,500 patients in each group. One was randomized to regular treatment, other to cerebral embolic protection device. And the neurological evaluation was also done in this device. And what they tried to see is simple incidence of stroke at 72 hours. So that was seen. And if you see, the baseline demographics were almost matching, though there were slightly more females in the Sentinel protection device. And the subgroup, which low risk, medium risk, and high risk, were equally divided, 30% in each, 30 of these things. So it is not only truly low risk or truly high risk, but it's a combination of everything. And then if you see the balloon expandable versus self-expandable groups, there are initially, as valve anatomy has decreased, balloon expandable were used more commonly there. I think 65% were those, and 35% were self-expanding. Predilatations, though it is tend to be avoided, which is said to lead to stroke, was also done in about 40% of patients in both groups. That means in either procedural characteristics or the patient characteristics, there are not much of difference between the two groups. But still, what the trial came out is there the slightly decreased incidence of all strokes, but statistically this was not important. And then disabling strokes, if you see the major strokes, which change the mortalities also, were significantly less in the group in which sentinel was used. So it is concluded saying that disabling strokes were less, but not all strokes. So we need further analysis. That was the ending. Mechanism of disabling stroke, obviously, most of it was ischemic strokes, which was decreased. And some intracerebral hemorrhage also could lead to some of these strokes happening in the sentinel protection device groups also. Some strokes which happened in the protection device group, when they tried to analyze and see what were the causes, fewer hemorrhagic strokes which can't be decreased by filters. And other things, other strokes happened in many of these patients, unfortunately developed other complications like valve embolization and various other problems. Only one patient in which a good complicated, uncomplicated TAVR was done had developed MCA strokes. So there was some other causes by which strokes happened even in the sentinel protection device cases that could be led to a lack of difference between the two groups. If you see, there is a bias in US versus outside US cohorts. In US, it showed significant decrease in stroke incidences. That is because the better, probably, they said that expertise and more usage of filters happened in US compared to outside US where there was, in fact, slightly increased incidence happened. So that led to neutrality of the trial. So we need to, with this again, the outside US people wanted to study it further. That's where I think BHF TAVI trial started. So British Heart Foundation protected TAVI trial again wanted to see that because they were thinking that incidence of strokes are less common, so population number needed to treat was more required. 7,730 patients were seen, and they randomized to sentinel protection group and to the normal group, and about 3,700 plus in each group. And this was not studied by neurological evaluations, but by and large 72-hour stroke was analyzed in these patients. The baseline characteristics were by and large same in this group. Self-expanding group usage was slightly more. So this is a thing, but one thing when we carefully analyze and see, even in this group, though the device group in which they were supposed to get sentinel, about 13% of them this was not placed at all. That is another problem with this type of conduction trials which we are doing. So you wanted to place a filter, but in significant number of patients, the filters could not be deployed because of the anatomy being the bovine nature, or only one filter, one side filter could be deployed in about 6%, and that's how there could be difference in outcomes. Again, this trial, large trial, ended up showing that there's no difference in stroke. So this is again a negative data showing that usage, that's how it becomes less and less popular. But if you see the various registries, the real-world registries, and some of the databases, and some center, a large center experiences, like Cleveland Clinic, who Samir Kapadia was largely experienced, if you see, there is some discrepancy in the data. If you see this, there's various sentinel studies, so many trials being done, right from inception to the more registries latest, and some of them are positive, some of them are negative. So, but where it is likely to come positive, that's where people started testing more. This is the beauty of the research, how it goes. Now, the valve-in-valve is one entity where you could have higher stroke rates. So this sentinel valve-in-valve trial was started. Again, 19,000 patients in each subgroup. Huge, again, number of patients. Analysis was done. Huge number of patients in which it was not used versus in which it was used. Though this is not randomized, but it is the registry analysis of those patients. If you see this, the overall stroke rates, major strokes especially, were less in groups in which sentinel protection device was used. And with 30 days and 180 days, also admission rates were also significantly less. So this valve-in-valve subgroup study of the sentinel showed the usage of sentinel device will prevent the strokes. One more step ahead, why we are also bothered of stroke is not only because of stroke, but it changes the mortality pattern. The people who developed stroke will have higher mortality. So this CEP stroke, some got strokes with CEP and even without CEP. Those patients in which strokes were there, they're analyzed and see what happened to those patients. Stroke patients with CEP, stroke patients without CEP, when they were tried to see and how these patients did follow up, see this. Hospital deaths significantly more, even in patients both developed strokes, but strokes without filters had a higher mortality. That means maybe the type of stroke which developed was more larger, in which filters were not used. So that is the analysis which further entered. This is an interesting data which was presented by Samir Kapadia. in the hospital Cleveland Clinic experience, once they started using sentinel clinics at this point of time, inflection point of time is around 2017, then the incidence of strokes, which is in blue, significantly decreased compared to those in which filters started increasing. So they went on to propose that probably usage of filters will definitely benefit these patients. They also tried to see their own hospitals' retrospective data, 1,000 plus in each of these groups, and showed that the strokes were less. It was happened only in few patients in which filters were used compared to those in which it was not used. Other significant difference is 30-day mortality, which was more in a group in which filters were not used compared to those in which used. So the patients not only had less strokes, but less mortality. That's another great thing which came out. The ongoing trials, the lot of new trials are being planned with various types of devices. These devices could be, so many companies are working on this new type of devices, because there are some fallacies of this existing Sentinel device which we'll touch upon in the case which I will show at the end. So some people are trying to see whether going through femoral with the better quality devices will help, or different types of nature of filters they're changing, and the assessment of strokes, whether doing only clinical assessment or MRI assessment will change. So many things are being tried and studied in the more of the trials are in the pipeline in future. So I would take the last few minutes to explain to you a little more. Some of you may not be exposed this much, so I thought I'll spend some time in Sentinel device which we used in few patients. Sentinel device is actually two polyurethane filters, 140 microns, deployed in the right brachiocephalic and the left common carotid artery, delivered to a 6 French. That's the beauty of this filter. 6 French through radial artery it goes. This is a cartoon picture which shows this is one filter which gets into the right side, this goes into the left carotid artery. So if you see this initial IDE trials showed some MRI stroke incidence was less, but again, clinically it didn't prove. So because now that we have two large trials showed that not much of difference of stroke, should we give it up totally? May not be, because again, we need to have some particular studies to show and which subgroup of patients which are likely to be beneficial more, which we need to see. So sometimes the patient expectations also as the clinicians we need to meet. Some patients demand, some patients want it, are educated. So we need to be aware and we need to be comfortable with the usage of this technique. That's why I'll show you one case example. The cost considerations compared to patients who develop strokes, it may not be much, because once they develop stroke, mortality increases, and when the patients were asked without even more than mortality reduction, they didn't want a stroke to happen. So even a few percentage, 1-2% patients who develop stroke, it becomes important to see, not to get into there. So device trial data and the safety aspects and further meta-analysis of these trials could tell us what best we can do. But as of now, in 2025, if you have to identify what are the best subgroups which you should try to use it, definitely. Probably valve-in-valve, where is a high incidence of strokes, and probably discussion happened in bicuspid aortic valve, especially type 0 ones, and where high calcium burden are there, probably could benefit by usage of filters. The prior stroke, definitely, and patients who had history of atrial fibrillation. That means where is the pretest probability of developing stroke is high. That's where I think you can try usage of filters. But sometimes it is important for us to be comfortable, because patients might be demanding in today's era, or where affordability is no issue, they don't want. We had one patient who had some age-related dementia type of picture. Somebody mentioned that minor strokes could happen and it could worsen. They came forward, though it was not very high-risk TAVI, but they wanted a filter to be used definitely. So such things could happen. So we need to become comfortable with the usage of it. Then sometimes we should also tell the patients that by analysis of CT or the prior angio, you may not be able to use the filter because of anatomy. That's I'll touch upon in the case example which I'll show. So the take-home messages now, before I go on to the case, is basically stroke is still a clinical problem, although risk is lowered, but stroke remains largely unpredictable. You can't be 100% saying that patient will not develop stroke. Sentinel device is a safe device to use and is associated with lower risk of disabling or major stroke. All the trials which came negative also showed that disabling or major strokes were less with the incidence of sentinel protection device. And sentinel protection, if not in all patients, especially in these patient subgroups, like valve-in-valve, bicuspid, heavy calcium, history of stroke, atrial fibrillation, and patients are requesting, you are supposed to use. And probably in this subgroup of patients, the time has come for us to use the sentinel device. But various newer devices which are more user-friendly and which would prevent further, we could be tested in future. With this, I will show you one or two case examples when we had no trouble, and other patient in which some trouble was there with the usage of this filter. So this is a case example of a calcific aortic valve. You see the motion there. The standard approaches, for the sake of time, I took the shots of filter only. This is how you are coming from right radial artery. Come down, you open up that filter. And this is actually real time. That much time only it takes. This is deployed the right brachiocephalic. Now we are trying to go into the carotid. See, that is all real time fluoro images I've recorded. So it is actually gone up. Then that's where after that, then probably you take this, if it goes down, then it will thread. This wire is same like 014 wire. You take this filter on, and once it is positioned properly there, then you, this is the right brachiocephalic, this is the left carotid. Only fallacy is left vertebral artery we are not covering with this device. So that is how it looks, and then once they are placed above, there's no problem. You can still carry on and do the routine job below. So that's how it is. Then there's regular steps. I don't want to go in detail, but we wanted to avoid predilatation because of risk of stroke. This patient had heavy calcium and bicuspid nature. We wanted to dilate. Sometimes balloon slipping happens inadvertently. That again could increase the stroke risk, but we did dilate again and took this Edwards valve again going through. While going through again, this word of caution is here is you don't whenever you get a pressure, I'll show you in the next case, you don't apply too much and try to change the orientation, do that. Then once it is gone inside, these procedural steps are regular. After doing the regular pacing, then see the position with the aortic root angio, then you're inflating here. Then that valve expands, it holds well. Then see that the filter is placed high above, you're working below. There's no interference with that. So that's where you do it, and once it is done, you check it, the aortic root, there's no problem. Then valve is deployed. Then this is the process of removal of filter, again real time. This is removing it anyway easy, anybody can do it, just pull it down. Once it comes into the sheath and then get it back, and then that is removed through radial directly. So later on, we need to also check the femoral arteries. Sometimes some material embolization could happen. That's what we have noticed. This is in the first patient, there is no problem. This is another elderly patient, especially the patients with 81-year-old female. When you are tracking, we didn't notice, suppose you see this, there's some small echo-dense structure which went across the valve. So sometimes of small materials in the aorta, then we could go there, and then the procedure was done successfully there in this patient. But in the end, when we were coming out, actually, the small peripheral embolism happened in these patients. So it did prevent the sentinel cerebral embolism, but sometimes we could land up with such funny complications too. With this, I would stop. I think we can have some 2 minutes discussion then. Again, I thank you, all of you, for making recent TCT India Plus a great success. And Samir Kapadia shared his lot of experiences in TAVI. Some of the slides I took from Samir's lecture. Thank you again for your patient hearing.